The lower cervical vertebrae from C3 to C7 are quite identical in their anatomy. And something that probably a lot of my colleagues have not been aware of, it's in reality the setup for all the lower cervical is quite similar, we could almost say identical. And for that, let's set up one classical way to treat the lower cervical spine when the patient is supine. Let's watch the video. So for the lower cervical, C5, we're going to take the slack out, make a contact, tuck the chin in, general flexion of the head, segmental extension, segmental lateral flexion toward the contact, segmental rotation opposite to the contact, and trust. Now, it's going to be the same thing if we have the patient seated. So now the patient is seated. I'm going to take the slack out, take my thumb contact on the articular process of C5, tuck his chin in, create a segmental extension at the level of C5, C6, segmentally, laterally bend my head toward the contact, rotate segmentally on the opposite side, and trust. Now, as you can see, we could summarize the different steps of that setup as follows. Retraction of the skin, take a contact, tuck the chin in, general flexion of the head, segmental extension of the head, segmental lateral flexion toward my contact, rotation opposite to my contact, and trust. So those are the different steps to perform that technique when my patient is supine in front of me. Now, if we have similar technique, in what those techniques are similar? This setup. All the cervical techniques will require the same setup. But they look different. So how are they a bit different? By two things, mostly. The type of contact used and the amplitude given to each steps of that setup. That's what differentiates them. So the contact, we can have a finger contact, a supported finger contact, we can have an edge finger contact, we can have the thumb contact, the thumb tuft, we can have a pisiform contact and probably more contacts than that. And those, we have learned that as different techniques. While in reality, the setup is the same for all of those. So the clinical interest here is evident. You know one setup, and you can do them all. Now there is another very important clinical interest. There is an intrinsic balance in all those lower cervical. And what do I mean with that? Imagine that if you put a lot of flexion to the cervical spine, you will need less rotation and less lateral bending. But if you put more lateral bending, you will need less flexion and less rotation, etc. So if one is increased, one motion, range of motion is increased, then you have to decrease the other one. So there is an equilibrium intrinsic to the cervical spine. And why is it such a very, very important clinical factor? Because imagine, we can adapt the technique to the pathology of the patient, to the physiology of the patient, its ability to turn the head or its ability to laterally bend the head. Now we can adapt to the patient by knowing there is a balance. And by doing that, basically, we're becoming much, much more precise in the delivering of our thrust. Remember, the setup for all lower cervical techniques is the same. And what differentiates the lower cervical techniques is the choice of the contact and the amplitude given to each steps. The clinical interest. If you know one setup in the lower cervical, you know them all, and you can create your own technique. The second clinical interest is that you can tailor the setup of any patient by balancing range of motion across spatial planes.